Hello, this is Tracy Hansen continuing on with the system assessment of the perioperative client. And I want to get a little bit deeper into the cardiovascular, respiratory, and renal systems assessment. With the cardiovascular, approximately 30% of surgery-related deaths are due to cardiovascular problems. So when you're looking at the cardiovascular system, consider if your patient has coronary artery disease. Have they had a recent MI or myocardial infarction, heart attack? Do they have a history of angina? And if they do have angina, are they on a long-term therapy, a long-term nitrate for that? Or do they take just sublingual nitro as needed for chest pain? Hypertension is very common and often is undiagnosed. So people will present to surgery for hypertension or with hypertension and not truly have a diagnosis of that. So that needs to be reported, as I said earlier. Also as dysrhythmias. So you need to be thinking about, for class, when we meet, what will your cardiovascular assessment entail? So I've touched briefly on it. But now when you come to class, we're going to do a systems assessment and look at specific things for our surgical client. So be thinking about that. With the respiratory system, do they have any chronic respiratory problems, such as smoking? And if your patient does smoke, there's a couple of questions you should ask. So what do you think those questions would be? In your mind, I know you're playing it, so what would they be? Possibly, how long have you smoked and how much? Smoking increases carboxyhemoglobin blood level, and with that they do have decreased oxygen delivery within the blood. And if you want to refer to that information, it is found on page 244 of your IGGI book, because carbon monoxide will end up on the oxygen binding sites of the hemoglobin molecule and making that hemoglobin molecule impaired when carrying oxygen to the rest of the lungs or to the rest of the body. They do have increased pulmonary mucus, and with that they have retained secretions. It predisposes them to pneumonia as well as atelectasis. And what specifically is atelectasis? Something to a point to ponder. When doing the respiratory assessment, there'll be specific things that you'll be looking at documenting, so be ready with that stuff for class. And then also of consideration is the renal or urinary system. When our patients have kidney impairment, it does inhibit drug and anesthetic excretions, and so we need to be cognizant that that will alter the effects of the drugs and the time it takes for anesthetics to be excreted from the body. So we need to look at renal function. It can also alter fluid and electrolyte imbalance. So what questions can you specifically ask your client? Are you probably going to go in and say, do you have any renal impairment? Probably not, because they're probably not going to know what you're talking about. So again, be thinking about those things and consider that for our class time assessment. Now we're going to move on to reasons for surgery. These are listed out in your book, your IGGI book, on pages, let's see. Those are listed out on page 243 of your IGGI book, table 16.2. So you will see on the left-hand column discusses reasons for surgery, be it diagnostic, curative, restorative, palliative, or cosmetic. And when you read this slide, they really make sense. Cosmetic obviously is going to alter and enhance the personal appearance. So you can be thinking about the movie stars that have cosmetic surgery. You know, Michael Jackson is a really good one because everyone knows how he altered his appearance cosmetically. So cosmetic surgeries aren't done on an urgent or emergent basis. Palliative, we're going from bottom up, palliative relieves symptoms of the disease. It doesn't cure the disease. So this could be your cancer patient that has an abdominal mass that is causing constipation, or maybe it has put so much pressure on the intestines that they have a bowel obstruction. So we're going to go in and they're going to take that tumor out to allow that person to be able to go to the bathroom, or maybe put a colostomy in. And so it's going to relieve that symptom of abdominal pain, of obstruction, but it's not going to cure the cancer disease. Restorative is going to improve patient's functional ability. So restorative meaning that you restore something to a body part. Restorative could be putting stents in someone's heart so that their life will improve in its functional ability again, because they're having perfusion and they're not going to have chest pain. Curative is performed to resolve a health problem. So we're going to take something out that's making our patient have problems. So that's going to be your diseased gallbladder, your diseased appendix. The woman that has continual blood loss needs vaginal blood loss and needs a hysterectomy. Those types of things. And then the top one, diagnostic, we want to know what's causing the disorder. Do we have a lump in our breast, and is it cancer, or is it non-malignant? So breast biopsies, exploratory laparotomy, looking around in the abdomen, looking to see if there's a problem, or the arthroscopies, looking in a particular joint. Why is my knee hurting? Why does my hip hurt? My shoulder? Those kinds of things. So you absolutely must know these reasons for surgery. So I would highlight that in your text so that you become familiar with those. And then what is the urgency and degree of the surgery? So that is on the box that is right next to the one we just discussed. And so is it elective, is it urgent, or is it a true emergency? Obviously a true emergency is going to be somebody that maybe is bleeding profusely and needs to have that stopped. Emergency could be a gunshot wound, a stab wound, anything like that, an abdominal aortic aneurysm. We have to pay immediate attention to that, or our patient is probably going to die. So those are the ones that we would triage to the front. Elective, that would be planned for correction. It's non-acute, so maybe a cataract removal, a hernia repair, hemorrhoidectomy, total joint replacement. So those things, they need to be done, but we could put it off for a couple of weeks. We could put it off for a month, and we would still be doing okay. Urgent, that's going to be required prompt intervention. It may be life-threatening if treatment is delayed. So an intestinal obstruction, kidney or urethral stones, these things, our patients can deal with it, and our body can compensate for those for a while. But if we don't correct them, then we're going to run into trouble. So it's urgent, but say you are working at Emmitsburg Hospital, Palo Alto County Hospital, and the surgeons travel from Spencer to these local hospitals, such as Emmitsburg, Pocahontas, Esterville, any of these local hospitals. So we don't have a surgeon in-house. So we have to wait for the surgeon to come. So can this person wait till tomorrow morning? Can they wait till that surgeon is finished doing the surgery that he's doing at the present time and then come to Emmitsburg? So that's going to be the difference between the urgent and emergent. And then next, the degree of risk. What kind of risk does that put on our patient? Or what kind of risk for long-term outcome? So obviously with minor risk, those are typically with local anesthetics. So it's a local injection of lidocaine, incision and drainage of an abscess, a muscle biopsy, mitral valve replacement, muscle biopsy, implantation of a venous access device. Now, those would be minor. Major, that's going to be a big risk for our patient. Usually those surgeries are longer in duration. They're extensive. And so our patient is going to be at major risk for something that might possibly go wrong. So again, pay attention to that box and know those. Extent of the surgery, is it simple? Is it just a small area that needs to be repaired? I put some pictures up here so you could kind of correlate what I'm talking about with these simple, radical, and minimally invasive surgeries. There's usually just a small area involved during a simple surgery, like taking wisdom teeth out. As you can see this picture, putting sutures into that foot or staples. And then radical, that's an extensive surgery beyond the area that's obviously involved. So a radical hysterectomy. So not only are you taking out the uterus, but you're also going to take out the fallopian tubes and the ovaries. So you're going to be doing a total hysterectomy with bilateral salping oophorectomy, if you would like the medical terms for that. Minimally invasive surgeries, these things can be done under scopes. So as you look at that picture next to minimally invasive MIS, you'll see that they are working with scopes. So it's going to be laparoscopic surgeries, be it lap appy, lap chole, a knee arthroplasty, a tubal ligation, coronary artery bypass graft. Those things can be done under laparoscope, and patients will typically do fairly well from them. I will wrap up this presentation and move on to the next. If you have questions about anything, or if anything is cloudy from the beginning until now, please write those questions down, bring them to class. If you don't want to ask, simply put them on a piece of paper, hand them to me, and I'll make sure that we discuss them. If you have questions, you need to let me know, because I don't know what you don't understand if you don't tell me.